but he's got other meetings after this. So thank you all for coming. I don't know, Lizette, do we have any new members joining us, or
I don't.
same
People.
pretty much
Which
same
is great.
people?
Yeah.
So yeah, it's good. So we can skip introductions, then we can maybe jump to the next item, which is the follow-ups from last meetings. Did we have any feedback from any of the organizations? Sorry, cutting out a little bit. Just, can you guys hear me?
Yeah.
Can you guys hear me?
Mm-hmm. Yep.
Hello?
Yeah.
Can you guys hear me?
I can hear you, Rita.
Okay, I'm just turning off my camera, just to save on bandwidth. So just wanted to get some feedback from anybody here from the members about last topic that we discussed. It was, I think, the monitors associations, and can't remember the other topic as well. Anybody wanted to just, yeah, that's a good idea. That's just pulling the meeting minutes.
There was
Device association was one of the meeting, items.
And that was operational reports.
Yeah, exactly. Yeah. And then ICU documentation. Yeah.
Rita, I did post on the or was that
Lumia library?
Yeah, on the library. So for people who have access to CERT, I did post on the library like a Word document with instructions on how to kind of go into the reporting portal. So if you do have the Lumio CERT and you have the generic name, you can kind of go in and have a look at those reports. They've been opened up.
Yeah, I might as well. Just what I'm thinking of doing is just share the Lumio library, share my screen on the Lumio library, and just maybe go over it, see if people had a chance to look at that with their organizations. So under change management working groups, you go
You're not
under
sharing your
nursing.
screen, Rita. I'm just seeing your email.
Oh, okay. That's the wrong one then. Can you see it now?
Yep.
Yep.
Okay, perfect. So so let me just start over. So if you go to the Lumio library website, you go to the change management working groups. And then if you go down to nursing, I skip over it.
Yeah.
Yeah. Go to nursing. If you go all the way, scroll down, you will see the INA reports file. We'll see the associate and dissociate devices, job aid. Some of those work, job aids. So is that the one, Kim, you're referring to, right?
Yeah, that's the one there. So it's the INA report. So it just shows how to get into it from the nursing position. So if you're logged in as the nurse RN using the generic count of Lumio CERT, then you would just click on the discern reporting portal, and then you would be in there to get the reports. If the report was a business objects report, it's going to take you to that lovely screen there, where you're going to log in as a nurse RN and Lumio CERT. But remember, this time, make sure the L is a capital, and then you can get in and have a look at the reports.
Yeah, so that's one of the things that we wanted you folks to share with your organizations. Maybe come back, get us any. I don't know if anybody wanted to share any feedback on.
Yeah, and definitely sharing with professional practice. They may be clinicians who may want to use these reports just to see, how things are happening on the floors with respects to assessments and catheter days and central line days and those types of things.
Okay, so Elizabeth, do you want to pull up the agenda again just one more time?
Yep. Oh,
Thank you. So we good to move on. Unless anybody wanted to share anything, questions from last meeting, any feedback? Go ahead, Donna.
Yeah, just if we had a few minutes, if if anybody wanted to share how the training is going, as as the training has sort of moved from the classroom, and the units are starting to look at their workflows and how the training is impacting that, and how they're starting to bring together their workflows with the training. If anybody had any successes they wanted to share, as small as they might be, that would be I think that would be a good way to start off the meeting.
Yes, go ahead, John.
Sure. I can share, Donna, I've been doing more ambulatory,
Mhm.
but it's sort of same, but ambulatory nursing. But a lot of what I found is that there are definitely a lot of workflow questions. One thing I've had the ambulatory groups look at is in the using dot phrases, being able to create templates to cover standardized workflows that they have, like for instance, discharge planners. They basically look at a few criterion when they write their notes, and the same for social work, the same for diabetes educators, like using that function. And I found that there's been really good response to that. I've encouraged them to get together as a department and work out some standard templates that they can use and share, and that way help to standardize their documentation and have it kind of as cues for themselves to make sure that those points are covered. I found really good response to that suggestion in the training groups I've had.
Oh, that's very good. Thanks, John, for sharing. Anyone else? Are there any major concerns that we're seeing before we move on? I know there's lots of questions, but is there any major concerns that you're having at your organizations regarding training and potential adoption?
And if we do have any questions there, I think those Lizette are still being populated to the Q&A log, right? From different sources, right?
yes.
That is true, Rena, yes.
Sounds
Okay.
good.
All right. Okay. I just wanted to ask that question, Rita. Do you want me to move on, or is there something else?
Yes, please. That's it. Yeah.
Okay, very good. All right. Hi, everyone. I'm Donna Laybourne. I am the workflow lead for the inpatient provider documentation and orders, and involved as well with the CPOE. And so we're going to take a few moments here just to provide you with a demonstration of what power plans or order sets, and they seem to be still interchangeably used. They're called power plans within the system, but we've referred to them regionally as order sets. So first we'll take a look and see around searchability, and there is a sort of prefix sort of template that's been developed in the style guide as they've presented the power plans and order sets. So I'm just going to share my screen. All right. I'm on the small screen. Hold on.
Yep, we can see the screen now.
I like to still see people. Something wrong with Teams today. All right. Okay, there we go. Okay. Is this big enough for everyone to see? Would you like me to try and make it a little bit bigger, or are we okay? All right. So what you'll do, as nurses in particular, right, is we'll go to our orders and we'll click on the ad if we're looking for a power plan. And then this is the sort of your search, right? And so as an example, I'm just using the admission. So the searchability is pretty intuitive, and you can most sort of any parts of the order set or the orders will populate down here in the search columns. You can see that this little square, Oracle calls it a pizza box, and that indicates that it's a power plan or an order set. Okay, so that's sort of the first thing. Excuse me. So for this purpose, I'm just going to use, let's just use, where's the medical? I just had it in the left here. And you can also, there's quite a few admission orders, but you can also see that, here it is. You can also see with the order sets that there is a prefix, right, that I talked about, and you can see where there's medicine, there's pediatrics, there's obstetrics, there's surgery or surge, and the CPOE team is developing a job aid with these prefixes. But again, it's searchability. There's ED as well. So just to sort of for maintenance especially, but also for searchability, that you can in fact search based on those prefixes as well. Keep in mind though, and this is that just because it says a certain specialty or area doesn't mean that it can't be used across specialties. So for example, the ED, they have a bunch of ED power plans, but also they could use the ICU vasopressor order set or a power plan if they have a patient who requires support hemodynamically. So they're interchangeable. They're sort of categorized in generalities, but they can be used across disciplines and across areas. So there's no restriction on that. So we now come into our medicine admission order set here, and you can see the title. And within the order set, there are messages or sentences that are for information. So there's usually an intent message, right? And then they're broken into categories. And the categories, again, it goes to the style guide. The categories are consistent in the order set, so they don't change in their sequence. And so you can see here, the first one is admission, transfer, and discharge. There's an intent statement here, and then you can see as part of the admission, transfer, discharge, you can see here that there's a resuscitation status or a goals of care status order. And within that, so you can see that it's not pre-populated. We left that intentionally because there's not always the opportunity to have that goals of care discussion depending on the situation. So we didn't make it mandatory and force that function. And so that'll go more to your policies. For example, I know if a patient is in the ED in Brockville, they, as part of their procedure and policy, that they'll need to be resuscitation status ordered prior to the patient moving to the ward. So again, that just sits with an organizational policy and process, but it's not been made mandatory. So next up we have are the diets, and you can see here it's too small, hopefully not. If you see two little pizza boxes, that's what's called a subphase. And so a subphase is a smaller group of orders that can fit inside of an order set, a big order set. So diets actually have several orders attached, and we've made the diet subphases mirror current state in terms of orderables. And so we've done lots of hard work on that. But you can see if I click on this and you go into here, you can see there's several orders here as well. Okay, so that's what the little pizza box or the little double pizza box means, I guess. And then you just, when you're done ordering what you need to order here, then you click back to the main to the main order set. Okay, activity is next, and you can see that here, not pre-populated. Vital signs here, patient care orders then start. Which includes respiratory care, assessments, any interventions, and lines, tubes, and drains. And then it's broken down into IV solutions, and there are, you can see here again, another IV fluid subphase that pharmacy has built, where you would be able to go in and choose which IVs. Click on this. Which IVs, and they have pre-populated order sentences for ease of use here. When we turn back outside of going into the subphase, there is also the need for, how are we going to get the fluids in? So we've, put in a saline lock here, but you can see there's a message right here. So for additional IV fluid options, please see the subphase below. So we try to encourage people to order from the power plans, or sorry, the order sets and the subphases for ease of ordering, so that they can see all of the choices that are available. So outside of that, there's bolusing and there's maintenance solutions as well. So medications, again, you can see they're broken down into subcategories that pharmacy have weighed in on. So VTE prophylaxis, and I know that is an accreditation standard, so that we choose whether they need prophylaxis or not, and then there's another subphase that goes in with that. And then any analgesics, and you can see there's a pain subphase and laxatives, glucose, bronchodilators, ancillary medications, and so forth. So there's also the ability to add to phase. You can see that here. So if a provider wanted to add a specific order to the admission order set or to an order set, they can certainly do that. Okay. And then that will get populated get populated within the order set. Excuse me. Then we're going down to laboratory. So that's where you're going to see all your labs, and it's again sort of subcategorized based on what we know. And then there's imaging, and then there's both provider consults and then interprofessional consults. And you can see here. So, so you would, they would go through and they would decide what it is they wanted. And excuse me. And they have the option within a power plan or within an order set, you can do two things. You can initiate it now, right? So then all of the orders become active right away, or you can plan it for later, which means it sits in a pending status. And I think, Kim, have you in the past talked about initiating orders as part of a process?
Nope. Well, just in the transitions workflows that we did.
Okay. Yeah. Perfect. All right. So, and I think, and I believe it's in training as well. So it really depends. And this is fairly new across the region. From a paper-based world, you would have been able to, fill out your order set or fill out your orders before they need to be initiated, and they would sit there ready to go. So for example, a patient who's coming from another organization, and when they arrive, the provider would have orders sitting there ready, although we know that that's not usually the case, but they can plan this for a future time when you would need to you would be able to initiate the orders then. So one of the complexities, we'll say, is that when you go to initiate the orders, right, as nursing, then there may be alerts that pop up and you'll need to actually then re-engage the, that's what you're going for, Heather? Yeah, she put her hand down. Then you would have to contact the provider to go through the alerts. We are working on, I will say, the clinical decision support working group. We are working on tidying up those drug duplications or those drug alerts so that we won't see so many. And we're working on that currently, and it should be ready to go post go live. We certainly encourage the providers to place active orders as much as possible, but in circumstances when they do plan for later, just you'll be prepared that there may be alerts that you may need to call the provider to address. Okay, these are not decisions that you should be making on your own. Would you like me to show an example of the alerts? Yeah, okay. So a pretty good one here is the bowel regime. So you go into the bowel regime here, and so there's a communication order for stool count if they want that. So say we pick lactulose, and Senecot is already pre-selected, so you can see some of the pre-selected, and Biscadil. So I'm going to go ahead. Some phase one has no components included. What is that now? Oh, this one, that's fine. I'll need to get rid of that. Hold on. There we go. Okay, so we've picked a few, so they're not the same drugs, okay, right? Senecot, lactulose, not the same drugs, but we're going to go ahead and we're going to initiate them. All right. So first thing that comes up, right, is missing height, weight, and allergies. They're required and they should be part of your admission documentation. We're just going to continue for the purpose of this. Orders for signature. When you do the orders for signature, you can see everything that is being ordered here, and you're going to sign. And we're going to refresh. Okay, and it didn't actually do it. So we must have done some of the work. We must be doing some of the build already. So what we've had happen in the past is we've had alerts pop up where, because of the drug classifications, so lactulose, Senecot, or if you're ordering Senecot as a regular dose and a PRN dose, that you'll see a duplicate drug alert. And with the duplicate drug alert, then it will actually say whether you need to, it's okay to continue, or whether you need to discontinue one of the orders, and that's where the provider will need to weigh in input. So, but it looks like we're working on some of that because that alert hasn't happened. So
sorry, Donna, we've had Heather hand up for a while.
Oh.
Do you want us to answer questions right away, or
No, that's fine.
Okay.
Yeah.
Go ahead, Heather.
And apologies if I missed it. I joined a little bit later today.
Mhm.
We included this initiate now versus plan for later in our admission hot topics last week. And one of the questions from the CLS group was, how do the nurses know when to initiate now if it is a plan for later order? So let's say the patient is admitted and the physician just selects plan for later. So a post-op order set is there an opportunity that the nurses, they should theoretically, I would assume, initiate them post-operatively, but what happens if someone goes ahead and initiates now and then those orders are live? Is it up to the nurses to decide when it's appropriate to initiate now, or how are they going to be flagged that they should move that forward? I just think it's a potential risk if it's different than our current workflow.
Right. Kim, if we address that in workflow, or
So can I take the screen?
oh sure,
Yeah.
you may.
So you'll see when the patient comes up from surgery and there are post-op patients, there's different phases of those orders throughout the surgical, right? They're going to have their pre-op orders, they're going to have their intraoperative, they're going to have their recovery room orders. So when the patient comes up to the floor, the doctor is going to have those inpatient post-op surgical orders potentially in this planned state. So when the patient comes up, the nurse in recovery room is going to discontinue those orders that are in the recovery room, and the patient's going to come up to the floor. And if there are orders in a planned status, they will be flagged here on the plans of care column. So that's how you're going to see that, right? And so I don't have a planned order status here, I don't believe. No, but what I'm going to do is when I see the orders in a planned status, I'm just going to click on them. It's going to take me to the orders section. Then I'm going to go and review the orders, and I'm going to initiate them now. The one challenge with this workflow is that if you have more than 10 patients on your patient list, you're not going to see the plans of care column. So an MRN, or the nurse who's responsible for the patient, isn't going to have 11 patients. They're going to have 6 or 7, so they're going to see it. But the in charge potentially won't see those orders in the plan status. But again, when the patient arrives to the floor, one of the workflow is you are to go in to get to review the orders. So you're the in charge, the patients come up, you're going to go into the orders and you're going to see the orders that are in a plan status that way. But that's kind of the flag that the orders are kind of there for the nurse to initiate.
So it would be it's up to the nurse's clinical judgment to initiate the orders at the appropriate time.
Yeah. So when the patient comes to the floor, they're going to see those post-op orders there. They're going to put them in, they're going to initiate them. It's a directed admit. The provider has already put the medicine order set in a planned status. When the patient arrives and the nurse is doing the admission, they'll initiate those or that planned status because the patient has now arrived to the floor.
Now, what happens if a patient, a nurse, initiates, say, post-operative orders pre-operative?
I can show you the phased.
Yeah, I'm just concerned that they'll have the wrong order set live.
Right. So yeah. So I'll give you an example here.
Perfect. Thanks, Donna.
Yeah, of what the phased order sets look like. Jessica, did you have a question before we?
I don't have a question. I was just gonna share with Heather at least how we've kind of tackled this at Quinte is like we're being quite specific in who we are teaching provider-wise, who we're teaching this workflow to. So specifically, this will be typically our surgeons and our who are doing emerge consults and then entering these phased orders like Donna was about to show. And the other thing will be things like maybe our ECT clinic or our medical day clinic who are planning future orders for repeat visits and things like that. But for the most part, for our typical inpatients, we really aren't teaching our providers about planned orders for that same reason. Like we wanted to be pretty confident that the nurse would know which phase to enact at what point in time. So for pre-op and post-op orders, we thought that made sense. But for most inpatient orders, we really didn't teach this because it was a workflow we were hoping our providers would avoid for the most part.
Okay, I will share my screen again. So what you see here is a phased order set, right? And so it carries it's small little subphases, like I spoke about, during a patient's journey at different moments of time. So if you see here under, and I chose the surgeon colon bowel sort of related procedures, right? Phased. You can see it's you can see there's a lot of subphases that go with this. And so, for example, right now we've clicked on this phase where it's the admission, transfer, discharge category, and you can see this, right? And then if the patient arrives and the patient is in clinic, then if there's clinic orders here, then there's these orders that they would choose from. And you can also see here, there's an order, power plan nurse to discontinue. So pre-surgical clinic orders phase to be discontinued, by the day surgery surgical nurse upon initiation of the preoperative orders phase. So there's your communication order to indicate when to go to the next phase, right? To discontinue this phase and move to this phase. And this would be the preoperative phase. And so speaking specifically, Heather, for those patients, right, that are coming from PACU, right, onto the ward, because I think that's specifically what you're focused on. So this order set, so again, there's the power plan nurse to discontinue, preoperative orders phase to be discontinued by the day surgery or surgical nurse as appropriate to transfer to the OR for a surgical procedure. And then there'll be post-operative orders that the surgeon will complete. Now, in between the surgery and PACU, they have their own order set as well that will get ordered by anesthesia usually. And then there'll be a little surgical component. So when I think about orthopedics, right, they like to have for hips, they like to have an x-ray, right? And that's usually typically ordered by the surgeon, not by the anesthetist. And so they also have in their phased order set to discontinue their orders when they're giving report. And then these orders would get initiated.
So there'll be a communication order as part of it. So that'll come up on their order set.
Yeah.
And then it'll say to discontinue. Okay, perfect. That's helpful.
Okay, yeah. So it works chronologically, and this does make it more convenient for the provider, although it will certainly take a while for them to sort of catch on to this, I suspect. Yeah, because it starts actually in an outpatient, an outpatient or a clinic step, right?
Mm-hmm.
So, and having said that, they don't need to fill out each piece as well. So, for example, pre-surgical, if that's not relevant, then they don't need to fill that part out, and then they just move down to the next pieces. Yep. Does that help with some of the workflow questions?
Yeah, I'm happy that there is that prompt or communication order to discharge the pre-existing one, so that's helpful. And then I liked, Jessica, that you guys are focusing on just teaching those, like, initiate now, because what I'm imagining, I just don't want people to be plan for later, but they should actually be initiating now, and then having the nurses decide, okay, when should I initiate them? But I think it makes good sense in that kind of pathway you laid out, Donna. I just want to make sure that's kind of what the plan is. So that's great.
And in the provider training, right, we don't talk a lot about when we talk about the plan for later, the examples we do use is regarding surgery, not so much. Not so much, like, it's sort of an advanced sort of workflow that maybe over time organizations would adopt better, but where it's really advantageous again is those from the non-surgical pieces when you're receiving a patient from another organization and you don't know when they're coming. So yeah.
Perfect. Okay. Thank you.
Yeah. Kim.
Yeah, Donna, when you mentioned the alerts, I just really wanted to highlight again around the alerts and the importance of when you are entering orders that are verbal orders, like there is a regional policy on verbal orders, and it really is, you shouldn't be doing them unless it is an urgent situation. And the reason, and when you are doing them, you should be doing them on the phone with the provider, because as Donna said, there are these alerts. So if I'm taking an order for a medication that the patient is already taking a similar medication, if I'm not there with the physician while I'm putting the order in, I'm going to get an alert that's going to have me reconcile this alert. So if I'm already on an antibiotic and the doctor orders another antibiotic, I could get this alert. So that's really that's one of the reasons why it really is important that we get the doctors to do CPOE. But if you are taking a verbal order, really trying to enter that order in when you're on the phone with the provider. So if there's any alerts, that you can get through them with the provider so that you can enter the order.
Yeah, I think so. So here I was able to get a clinical decision support alert here, medication. So you can see here there's a duplicate for.
You need to share your screen.
Oh, shoot. Didn't I do that? Okay. I was
Well, you
talking.
did, but I think we took it away from you.
Oh, you buggers. Okay, sorry. Sorry. Okay, so here we are. So here is a medication clinical decision support. So you can see here that there is what's deemed as a duplicate therapy, right? So because I had ordered heparin as well as enoxaparin, and so it's saying here that you shouldn't have both. So you would need to, as mandatory, so you would need to talk to the provider and say, hey, you've got both of these things. What do you want to do? Do you want one discharged? Or more importantly, you could say, could you please go in and fix the order, right? Modify the order. So that you can get rid of the alert. So prescriber clinical judgment or or consulted, or you can go ahead, or you would be able to, oh, sorry, select the override reason. You should be able to do, oh, here, remove new order. So then they remove it and they'd have to place it again. So that's an example of why it's really important. So, okay, any other questions? No? Okay. All right, sorry, it was way more than 10 minutes. I'm so sorry.
All good.
We'll move to the medication administration part, the titratable drips now.
Okay, I'm going to take this one on, so let me just make sure I can share my screen with you all as well. And this was an ask that came up maybe 2 meetings ago from this group, was that there were questions about how we would titrate continuous infusions. Can you guys just let me know if you can see that?
Yep.
Perfect. Thanks, Rita. Okay, so I've put in some orders on a practice patient here, and you can see that we've got a couple of continuous infusions under this IV solution section here. So my patient's got an order for phenylephrine. They also have an order for Levophed here as well. So what I've done earlier, I'm going to go to the MAR. So typically, if I was a nurse, I would be able to grab these orders from Care Compass. It would get a little starburst that would tell me I have new orders for my patient. I'd be able to grab and review some of these orders here. I've already done that just to get one of these medications started for us here, but that's typically how the nurse would be alerted that she has pending orders. So if I switch over to my MAR here, you can see about halfway down the screen here that my phenylephrine is infusing. Down under this administration information, you can see that there was a bag that was started at 100 mics per minute at 8:59 this morning. I'm just going to refresh my screen here. If I wanted to, then from this screen, I can titrate this medication. And I'm going to show you that quickly, but we're going to see how to do that in a couple different formats. So if I had this bag already infusing on my patient, I'm just wanting to titrate it because my patient is remaining hypotensive. And I've been doing additional care. Maybe I'm in here documenting vital signs. So I've gone into iView. I could document vital signs on my patient. They're still hypotensive. I can move also then to my titratable drips. And in here, I can see that I also have my phenylephrine. So if I need to titrate this from my 100 mics per minute that's currently infusing, I can do it really quickly in real time at 10:41 by double clicking the box beside mics per minute and just entering my new rate. When I enter that, you'll see that that's auto-calculating how many mils per hour that is for my patient. It's coming up in purple text for me, telling me that I need to sign it. So if I do so, I'm going to see that that's now reflected through this titratable drips portion in iView. What I can also do from here is move to my intake and assessment. And I can see that some of this will auto-calculate for me. So if I double click in this box, from 10 to 10:59, the total amount in mils that my patient has received from their phenylephrine infusion is 63.8 mils. I can also look at some of these previous boxes based off of what was infusing in that hour rate. to input all of the input that's come in through that IV solution that's been hanging for my patient. So it's nice that you can see that communication on both screens. It's going to make it really easy for our ICU nurses to track input like that. Just for this example, the other thing that I want to show you all, or sorry, I should, anybody have any questions on that piece? That iView titratable drips makes titration very simple and easy. That's good. Okay. So the second thing I wanted to show you then was, let's say that this patient continues to be hypotensive. I also have orders, for example, for to initiate a Levophed infusion. So doing this a little bit backwards, because of course I don't have a barcode scanner. So I should be scanning this patient's armband. I should be administering this medication and starting this bag through the MAW, this medication administration button up here in the toolbar. But for right now, I'm just going to do this the quick way for our sake. So if I double click on this, I can start a new bag. So this is a new infusion. I'm starting bag 1. I'm going to start it in my patient's CVAD. And I can see here that I'm getting Levophed infusion, 4 milligrams in a 500. I can change those if I need to. I'm also starting that Levophed infusion at 2 mics per minute. But again, if my patient's already on 120 of phenylephrine, maybe I'm going to start that higher based on my clinical judgment. So underneath here, I'm going to click apply now that I have all of the correct information in. This is telling me that my initial parameter to initiate this rate was 2 mics per minute. Do I want to continue? And in this case, I'm going to say that yes, based off my clinical judgment, I do. So I get all of this information that I've just input right here. I can sign that, and I'm just going to refresh so we see it reflected on the patient's MAR. So at 10:43, we've begun this bag of Levophed at 4 mics per minute. If I was already in here, I can also bolus my patient if there was any reason, and I could document that in here and click apply. I can also do a rate change. So you kind of have two options on titrating that medication. So in here, I could also say, patient remained hypotensive. I've already increased it up to 6, and I'm going to apply that change as well. If I sign those and refresh, we'll see that all reflected in the MAR. We'll also see that rate change that I did from iView down here reflected on my phenylephrine from earlier. And like I said, all of these screens are talking to each other. So if I go back to titratable drips in iView, I could do all of that documentation as well from this screen. Oops, by double clicking and changing my rate again, if still required. Oh, sorry, didn't sign that one. But Cerner actually makes titrating these drips quite easy. Any questions on that? I know that was a workflow that was requested by someone previously. Okay.
No question, Jessica, but that's fantastic.
That was the quick and dirty. Okay, well, thanks, everybody.
Yeah, thank you very much, Jessica. You make it look so easy. All right, we have some time left. I don't know whether anybody wanted to ask any questions or share any ideas for the next topics. We're ahead of time here.
Actually, Rita, we're actually probably not ahead of time because we
We're
were just
not?
gonna. Yeah, I feel like we are gonna do a little bit of the PCA. I was just gonna show some of the documentation there. I'm sharing my screen, and that was great, Jess. Great demo. I also just wanted to point out a few other things about intake and output. Jess had showed how it can come in from your solutions. Similarly, I put in an IV solution this morning, sodium with KCl. And again, I can click on that for each hour, and it's going to fill in my infusions for that particular IV. I gave a bolus this morning as well. So this was a saline bolus. And again, you can see that 250 bolus I gave pulls into intake and output. Other things that will pull in here is if I'm giving like a Rocephin IV. So in that order, it has a volume of fluid that I'm administering with, that's going to flow here. I give my saline flush. So I'm going in and, I got a PIC line or a central line, and I'm doing some flushes. Those flushes, that volume's going to flow in here. Other things that I wanted to show just for the intake and output, how like different parts talk to each other is in the output. So here I actually did some documentation for a catheter. And in that catheter, I have irrigation going in because it's a CBI and urine coming out. So it calculates in my documentation true urine, and my true urine is pulling in here to my intake and output. So it's really great. Lots of that documentation that happens in iView that's documented for fluids will pull here in during intake and output, and you can get your balances. So I too have a medication, and I started it yesterday. So mine is my PCA pump, and I feel it's my top med here. Yeah. So I'm going to say this is the order. It is a morphine PCA. It's ordered as part of a power plan. I have the order details have been completed by the providers. So I have, it's a milligram per mil. It's going at 2 mils an hour. I've got a PCA dose of 0.5 milligrams, a lockout of 15 minutes. I got my basal rate there, and I got my dose limit of 3 milligrams. So that's the order. The provider fills that out. And then I would go through the MA, I would hang that bag and do my scanning and everything. I feel with this particular medication, I am going to get a second signature. So in my interactive view and intake and output, what else do I have to do for this particular infusion? So the first thing I'm going to make sure I have is my documentation. So this is a subcutaneous infusion. So I went in and I've already documented my infusion setup. So that's when you come here, you're going to click on your little graph, and this is how you pick your sub-Q set. And so you put in the type of infusion, the site, the laterality, and then you hit OK. So with that line in place, the clinician can go in and do the necessary documentation with respects to the line itself. The other thing, because this is a PCA, I'm going to be documenting on this. And so I'm just going to actually change my documentation to the last 48 hours so I can look at my documentation from yesterday. So I'm the nurse, and I was in here. I put in that it was a routine assessment. I put in my continuous rate, the unit, my demand dose, the measurement of that, my lockout interval, my dose limit. So that's my demand dose in conjunction with my hourly dose. What's the maximum I give, my milligrams, and then the interval for that maximum dose. So other things I can document is the number of attempts that the patient made in terms of the PCA, the number that were actually given. If I was the nurse and maybe I gave the patient the additional dose just because the patient was, not responding, but I could tell by doing my FACES assessment, they were in pain. I could just right click and add a comment and put in a comment that it was a nurse administered dose if that orders were allowing me to do that. Then I can document the amount delivered, the unit of measure, and my pump activity. It's just, giving me some things I can choose from. The volume infused in the current period. Did I switch it to a home care pump? Extension tubing added. Getting down to near the end of this is kind of what I wanted to point out is our double checks. So I have double checks that get done on a PCA pump. So I click on this. These are the types of double checks. So my changing of my settings. If this is an initial pump setting, my new bag or syringe cassette, change of caregiver. So that's where I could do that one. And then the double check elements, I'm going to click on here. So me and Jess, we did our double checks. I'm going to put my correct drug, correct concentration, correct PCA dose entered, correct infusion, correct dose limit, line reconciliation, corrections were made. Perfect. I'm going to sign that all off and I'm going to hit my little green check mark. Oh, and here I come to my second signature. So person who is doing the witness is going to put their username and their password in here. And that's kind of how you would document on your PCA. Any questions? Perfect.
So can you document it on the iView as well as the MAR?
No, my PCA is being documented here, the things that I'm doing with respects to that. Where I've documented on my PCA is on the MAR is that I actually hung the PCA. This documentation here is just in iView.
Mm-hmm.
Okay.
That looks fantastic. How's everybody feeling?
I did create some workflow documents for the PCA and the titratable drips. So we'll post those in the Lumio library if anybody wants to use them to help with training or just reinforce or as an education tool, they'll be there.
Yeah, it's going to be good if you know, the members here could take them back to the orgs and, you know, share those from the Lumia library what we looked at today, and then
Okay.
maybe get back next time.
The other, I did get a question this week from one of the sites, and it was just around the hazardous drugs category 1. And I don't know if it got covered in the training, but I just wanted to just highlight that there is this opportunity where you can highlight on the banner bar that the patient is on a hazardous 1 chemo drug. It's a shared responsibility between pharmacy and nursing. Pharmacy are going to be adding that alert if they are doing the orders and they see those category 1 drugs ordered, but as well a nurse if they were doing the admission history. And they identified that the patient had received it within the last 7 days, they themselves can add that alert. I just wanted to let you know that alerts get added through this PM conversation. The nurse would come up here, they actually click update alerts.
Oh, you're actually not sharing.
Oh,
You're
sorry.
showing something.
Sorry. Hey, the nurse would come up here to the PM conversations. They're going to access update alerts in here. I'm going to put my Kingston and it's going to find my KGH. I'm going to hit OK. And I get the screen that pops up, and this is how we add process alerts. So I click on the process alert, and these are the alerts that are there. So the AOB is an alert that gets used if a patient is going to be flagged as violent. The hazardous drug 1 category. There's also an alert here that's called Hospital at Home, and this is for Kingston Health Sciences and Quinte Health. And then there's also the Transition Home Program. So those 2 ones are just to alert clinicians that the patients, when they're in the hospital, are these types of clients. So I'm going to hit my hazardous drug 1 category. I'm going to hit move. I'm going to select OK. And then when I do my little refresh, you can see up here that it's now on my banner bar. And this lets people know that this patient is on a hazardous drug 1 category. So I just wanted to reinforce that. It was just questions that had come up this week.
Kim, can you click on clinical leader organizer? Does that show up anywhere? I'm just thinking in terms of assigning patients.
No, it does not.
Okay, all right.
Yeah, it is on,
So it's at the chart level. Okay.
It is at the chart level. So if I'm on the floor and I've identified that the patient is a category 1, and I wanted to identify a little bit more details, I'd put it on the situational awareness on the handoff page. I could come in here and in that situational awareness, I could put down that the patient feel like it's not 100% there. So I'm going to have a look at that because I don't actually see my situational awareness kind of working. So I'm going to have a look at that. But that's where I could put it. I could put a note on that the patient is on cytotoxic precautions and is taking a particular medication weekly. So I could make note of that because that information would be viewed on the handoff page.
Perfect. Okay, that's great.
Yeah. I feel it's okay.
All right. That's great. Thank you, Kim. And thank you, Jessica and Donna, for that amazing presentation. And we're at time now, but feel free to forward any topic ideas to myself or Lizetta, and we can have to plan to have those discussions, hopefully.
Yeah. Rita and
Yes.
Rosetta, have we talked about goals of care, about the new model that's coming? Have we done that?
I don't think we
What do
have.
you, what do you
right,
think,
Kim?
Yeah, what do you think, Kim? Would that be something for we could do next week?
Yeah.
Yeah, I'm happy to do that. Okay.
Okay,
Is there-
Lizetta, can you add maybe Donna to our planning session?
You
Yeah.
got it.
Yeah. So. All right.
Awesome.
Okay, and then I do have a little document around the adding the flags. I will put a screenshot in of the situational awareness once I get my computer working in that. So I'll add that to the document. So you'll see exactly how it would look.
All right. All right. Heather Macklin, once everybody leaves, are you able to, or actually, I'll just call you. Do I have 2 seconds to call you after this meeting?
I have an interview that starts
no,
right now.
that's more important.
That's okay. I'm free at noon if you want to call me.
At noon, let me look and see. No, I've got something at noon. What about 1:30?
Yeah, I have budget stuff, but that's fine.
Okay.
Call me then. It'll get me out of my budget meeting.